Good morning, everybody, and welcome to our most recent webinar. Delighted to have Henley sponsor this fascinating subject. And this morning, we're going to be talking about the pivot to virtual healthcare, just what the doctor ordered. In this COVID context, we've seen the rapid acceleration in digitization across all our businesses, and the healthcare industry has been the one that's been at the forefront of fighting COVID, but equally perhaps at the forefront of adjusting to the new environment in which we find ourselves. I'm really delighted to host a really distinguished panel this morning, who I will introduce shortly. So firstly, John Foster Pedley, thank you very much, the Dean of Henley Business School, Africa, who we know quite well. Peter Cruz, distinguished clinician, Rhodes Scholar, international experience, and I will not do him justice, so I'll let him introduce himself shortly. And Naren Basu, again, a distinguished clinician, surgeon based in the UK, but hailing from Africa, having internships and studied at the universities of Harvard and London University as well, and the Marie Curie Institute in Paris. Just a bit of housekeeping. This session is going to be recorded. I do encourage you to interact with the panel using the Q&A function on your Zoom, and please do look out for the polls, which we will be conducting throughout the webinar. My colleague and Vice President Cecilia will be feeding in your questions to the panel throughout the morning, and Ema is in mission control running the polls. But to get us in the mood for interactivity, the quick icebreaker is, who is your favorite doctor? I know Cecilia is particularly proud of this question. Ema, perhaps you could flash up the first poll. Who is your favorite doctor? Present company excluded, so we can't vote for Naren or Peter. Doctor Who, Dr. Dolittle, Doctor Strange, or Dr. Zhivago. I'm a Dr. Zhivago fan myself, but just to get us all in the mood for kind of participating and interacting. Perhaps, Ema, you can flag those as I'm introducing John, the Dean of Henley Business School. I'm really excited this morning, so I'm working with my team here in South Africa, but also, John, I think it's known that you're my oldest friend in South Africa, not in terms of years, in terms of people I've met since I've been in the continent, I should say. And Naren is perhaps my oldest friend in the world from, we were actually at boarding school in the UK together many years ago. Ah, great, like-minded individuals. You can see Dr. Zhivago is a third of us, is our favorite doctor. So we're quite a literary bunch. Perhaps in the comments, we can confirm who wrote that. We're debating whether it was Dostoevsky in the office yesterday, but I forget. But again, John, perhaps you could tell us, Henley's brought in a new course to address some of these changes in the healthcare space. So actually could give us a quick overview of yourself, Henley, this particular Future-Proofing Your Health Practice course, and then I'll let Peter and Naren introduce themselves and they can comment. Good morning, John.
Good morning, Leon, and wonderful to chat to you and to all the members and guests, and to meet you, Naren. I know Cecilia, and now I probably am your oldest friend now, actually. You know, I think lockdown does it to all of us. But anyway, so I met Peter ages ago. I was running an MBA in Cape Town, and Peter joined it. He didn't need to. He had all sorts of qualifications, you know, rafts of them. If he'd been in the army, he'd have all these medallions down his arm and chest and everything. Anyway, of course, he waxed it and became the gold medal winner, as Peter does, and we kept in touch for a long time as he went off to go and open hospitals in the Middle East and do many other interesting things. And he came to me and said, look, you know, beginning of lockdown, he said, look, we've been thinking about this for a long time, and obviously, wouldn't it be a good idea that we do something to help doctors virtualize their practices? My wife's a GP. And it's difficult. I understand how difficult it is. And so we said, yeah, great idea. And we're actually going to open a healthcare school. So Henley is a large international business school. It's been around for 75 years now. I think that is the oldest in Europe now. And we've been in South Africa for coming on 30. I've been there for about 10 years. We do MBAs, a whole range of other things. And we're quite interested because we have Henley Europe, Henley Africa, and Henley Asia. And we run MBAs, but many other things. But the things I enjoy most are this sort of work, because our motto is we build the people who build the businesses that build Africa. You know, and medicine and healthcare, you know, with all the craft and practitioner and deep, deep science and depth around it, is also a business in a benign sense of the word, because business is something that should bring value to society, not exploit value. I mean, that's the whole point. It should create value. And healthcare does in the most magnificent way. And so when Peter suggested this, we said, right, let's run it. And then I have to say, I'd like Peter to talk about that because he's done a really good program. Part of my background as a pilot, as an airline pilot, And I mention that only because of the parallels between flying, in a sense, and safety and medicine, and also business. There are disciplines that you manage in very complex, fast-moving, dangerous situations that are important. I think we need to bring them into business. I think we can learn in general business from what we're going to talk about here. And I think we can draw in from each other's experience, and let's see what we can do. So thank you very much for inviting me. I'm looking forward to the conversation.
No, thanks, John. And I've always enjoyed, since we first met some 8 years ago, comparing our military backgrounds, you in the Air Force, me in the British Army, but also your kind of whole philosophy at Henley around business for good. And again, it does tie, and it's worth remembering that as the Chamber, our purpose is to create an ecosystem whereby we can all grow. We believe in sustainable capitalism, sustainable leadership, and building sustainable organizations. And I think we all accept the premise and the hypothesis that trickle-down economics has failed. Therefore, we have to challenge that model and paradigm. And no more can we see that in terms of saving lives within the healthcare industry. Peter, you've got such a rich background, an international South African. And what I love doing is, I'm a Brit who's adopted this country, who's been here for many years. I like to celebrate South Africans that have that international lens and international experience, but choose to still stay here and be proud to be here. And we were talking before we went live on, you actually moved back to Cape Town. But before we approach the course that you've addressed with John, maybe give us a bit about your background and experiences that have got you where you are today.
Well, thank you very much. I'm also delighted to be invited to join this panel and to meet all of you. And it's part of the mission that John and I share. Very briefly, I was perhaps a little bit precocious as a youngster, and I got a chair at UCT in my early 40s as the chief specialist at Curtis-Care Hospital, where I was in charge of, originally, of more than 500 clinicians, including 15 professors across many sites. And I realized as a kind of mega manager that I was lacking the intellectual glue that I needed to manage such a large operation. I had managed small practices before, but so I decided to do an MBA, and that's where I met Jonathan. And the link is quite interesting. I did my major project thesis on digitizing and virtualizing my own discipline, anatomical pathology, which, by the way, isn't about Quincy and autopsies. It's mainly about operating theaters and going in and diagnosing the tissue abnormalities that surgeons find with them. It's a very close collaborative function, which Naren can enlighten. There are lots of jokes between pathologists and surgeons. We tease each other all the time, but actually the surgeons and the pathologists work well. And I like to call myself a surgical pathologist rather than, just a pathologist. So I spent 40 years doing that job in operating theaters all over the world. Once I did my thesis and handed in this project and finished, I was poached to go to the Middle East by the Minister of Health of Saudi Arabia. And then I got into applying my MBA, which is one of the action learning things that we love to do at Henley. And I was then given a massive job in charge of essentially the pathology services for 1 million people across the country on 3 sites. And my job was to, I really had one line. It was, what's wrong with the laboratory service and how can you improve it? So I was given resources and time to implement all those changes. And this gave me an appetite for applying the managerial and operational knowledge that I had learned on the MBA. And then I just wanted to say that one of the guiding drivers, apart from COVID, that's helped us develop this course is the recognition that in most parts of the world, and I'm generalizing, the clinicians have been amazing in the way that they've responded to patients on the clinical side of COVID. But generally speaking, our feeling is that they've not been quite matched by the managerial and operational and logistic side of healthcare around the world. And so we recognize that this was a gap in the education of doctors in particular, who are not taught about operations management, staffing, scheduling, finance, HR, and so on, which is the stuff of business schools. I then did some work when Jonathan and I were looking at how to run this course. And I found some papers from America showing that where medical schools and teaching hospitals were closely located to business schools, or where they had collaborative arrangements, clinical outcomes in those hospitals were better. Managerial outcomes were better. In other words, they didn't go into administration, as happens to some of the great hospitals all around the world through mismanagement. and they also had better patient satisfaction. And so we're interested essentially is to see what can the business side of healthcare contribute to strengthening the healthcare mission throughout the world, and particularly in Africa, where healthcare and education are the two pillars of nation building. So it was fairly logical for me at the end of a long clinical career to follow my heart, I think as Naren did too, and come back to South Africa and apply my shoulder to the South African wheel, which is the country of my birth. I was very blessed to have an education on scholarships to Oxford and the Hammersmith Hospital, Royal Free, etc. So I worked in the NHS for almost 20 years, so I understand that system. And there's a huge amount of knowledge that Europe can give us in South Africa, where we are challenged with the third world, if you like, the developing world burden of disease, but we have the first world brains and technology to solve it. So that's the challenge we face. Thank you.
No, thank you, Peter. And there's something about the synergy of our ecosystem in terms of you being educated as the British Chamber of Southern Africa and the SADC region, but you being educated in the UK, but coming back to Africa to solve problems in the Middle East for Africa, but for the rest of the world. And me now introducing my old school friend, Naren, who I'll let him introduce himself. He indeed hails from just north of us up in Zambia. Perhaps Naren, just on the back of what Peter said, tell us a bit about your journey, your education. I'm really fascinated. I know you're managing the largest breast organization in the UK presently, but leading up to how you got to that role and indeed the creation of the Birmingham Breast Group. So perhaps take us back to Zambia where it all started.
Thank you so much, Leon, and thank you all for allowing me to be part of this really great webinar. So my heart is in Africa, without a doubt, and I'm really privileged to be having the opportunity to strengthen those ties. I sort of started off in the Copper Belt in Zambia, and then we moved to Lusaka. We were part of Lonro, which has sort of historic ties with London and Rhodesia and Tiny Roland going back a bit. And we were expatriates living a great life in Zambia. And then I went to boarding school in the UK where I met Leon. And then I did all my education in the UK. I've been very privileged to travel the world and do some work at Harvard Medical School and Institut Curie in Paris. But I have to say my heart is in Africa, and I haven't been back for a while. What we recognized very early on is that breast cancer, it could be any disease process, but if we use breast cancer, it's the most common cancer that we see in the developed world, and there's a significant burden of disease in Africa as well. And we find that people present quite late on. And what we realized was that there's a real opportunity to actually provide this group of very vulnerable individuals the expertise all under one roof. So we developed what's called the Birmingham Breast Group, and that's a number of 17 healthcare professionals, along with Leon and Cecilia's guidance. And we're here to really serve the wider population. So if anything, this webinar is testimony to the fact that we can be continents apart, but have a meaningful discussion. And what we're hoping to put forward there is a multidisciplinary approach. So you don't just have Peter as the person whose sort of expertise is under the microscope, and apologies for limiting your expertise there, Peter, or the surgeon or the pathologist. It's the whole spectrum. So I worry that people don't get the whole spectrum of care, and that's what we're here to do, end-to-end, seamless care, and we bring that really to your doorsteps in Africa as well. So that's my background. I'm massively excited to be here. So a massive thanks to all of you.
Thanks, Naren. I think we can maybe just dig into that a little bit more at this stage, because I think the very fact that you said we're continents apart, yet we can work together, and we're going to look at virtual diagnostics, virtual engagements, and indeed our audience appetite to engage in such. But talk us through how an EMDT might work and the multidisciplinary nature. Give us an example.
Okay, so I can give you two examples. So one is a very real life example of I've been asked to sit on an expert advisory panel of a group that actually sit in Egypt. And what they do is they gather referrals from a number of specialties, and then they send that medical work by email to individuals like myself. I review the information and then I formulate an opinion, and that's already there. Ours is an extension of that. Ours is purely for breast, and that one could use that as the model that then is used across other specialties or other areas in medicine. But what we do is we look at the same problem with different lenses. So if there's someone, for example, with breast cancer sitting in Johannesburg, what we would hope is that their clinicians would send off all the information to us, imaging, pathology, a clinical letter, and then we get our heads together, the 17 of us, to figure out a comprehensive care plan. And I imagine it will be very similar to what is already being done in South Africa or Zambia or Zimbabwe or Ghana, because I know the healthcare is excellent where you're sitting currently. But what perhaps you lack or we lack is the integrated multidisciplinary approach. And we're not asking for patients to travel from Joburg to London or Birmingham. What we're asking is that that information can be sent over electronically. We can discuss that, and then we can make some recommendations. And it makes the world, and the world, if anything, during COVID has become so much smaller, but it makes healthcare transferable across continents readily. So I think that's the sort of scope. And if this is successful, and we've got every reason to believe it will be, because we've now actually got the software, we've got an MDT electronic platform that we can take across continents, it's hopeful that that model can serve as the template for further disease processes. Does that answer your question?
Yeah, that's helpful now, and I think what that's really done is kind of open the door around three key themes that I think we're going to jump into. I think John and Peter touched on the first one in terms of the ability for clinicians to manage. And now, before we went live, you were telling us about the backlog of surgeries that's required in the COVID context, which perhaps we can explore. Clinicians having to manage healthcare organizations from the clinical perspective up to speed. Are we up to speed from an operational management perspective? Peter superimposing his MBA learning onto the clinical sphere, which not every clinician has the opportunity to do so. So that's how we can partner with organizations like Henley to upskill. But then equally looking at how we can give access. So you could be in the copper belt, but you could have access to experts such as Peter and yourself virtually to really perhaps improve healthcare and social outcomes for not just Africans, but for people anywhere in the world. On that theme, I think it's an opportunity to go to our audience, and perhaps, Ema, if we could run the first poll, which is really gauging our own appetite as patients to indulge in a virtual consultation. I will read out this so it shows up in the recording. Have you ever had a virtual consultation with a medical professional? Yes, worked well, you'd be happy to do so again. Yes, your preference is for in-person consultations. No, but you're open to trying. No, you want to stick to the in-person consultation. I know in the COVID context, particularly for my mother, who is a cancer survivor, she's been very nervous to go and have in-person consultations because she's deemed vulnerable. So it would be really interesting to gauge the audience's appetite. Perhaps, Ema, you can just flash up those results as and when they're ready. Interesting. So we can see that 11% happy to do so again, 11% in person. The vast majority is saying no, but we'd like to give it a try. Perhaps on those themes, and perhaps looking at Peter and then to Naren again, what new diagnostic tools and technologies are available to address these virtual consultations? Are there specific disciplines and specialisms? We've touched on breast care, cancer care, Naren, that are particularly well suited to this virtual approach. And indeed, what is the technology enabling remote diagnoses? Perhaps, Peter, if I look to you first, from your experience, what are you seeing?
Well, I think what our course has taught us from feedback from presenters and also from clinicians who attend the course. So we get more than 50 people an evening on the course, and most of them are GPs or specialists, and some are from professions allied to medicine like physiotherapy, occupational health, etc. The example that Naren gave is an obvious one for improving the quality of diagnosis for patients. I ran a tissue review process when I was working in labs in Saudi Arabia, and many hospitals have this, where there's an obligatory review by a multidisciplinary team of any patient that has a diagnosis of cancer, whether they're coming for treatment or not. And this service is usually provided at no cost to the patient in the interests of improving the quality. And it's sad to say that, without pointing any fingers, that many patients have their tissue or their imaging or their clinical diagnosis, which is a mistake, that they were misdiagnosed in some country, and that diagnosis then stuck. In some cases, they were even given chemotherapy or something quite nasty. And then when you come to reviewing it, and what the review does, as Naren outlines, is it puts the power of collective intelligence. You may remember Al Gore wrote a very good editorial once on the power of distributed intelligence. Human beings work much better when they collaborate, and you have 3 or 4 minds, or 5 or 6 or 17 applied to a problem. And that's where patients get the best deal. So not only did we discover quite a lot of overdiagnosis of cancer, but in some cases there was underdiagnosis or misdiagnosis. And while this is not a huge problem in number terms, fortunately, it is an example of where we've started to copy, as Jonathan was saying, the aviation industry, where quality assurance is part of what we do. And we know that adding value is not just economic value, it's about raising the quality while lowering the cost. This is the equation. So that's one example. And then last night we had Professor Vicky Lee, who's the only professor of digital healthcare that I've met so far online, who works with us at our sister university, Henley on Thames Business School. She was outlining all the other diagnostic modalities. We were looking, for example, in a case study at continuous glucose monitoring of diabetics, which is coming along nicely, where a sensor that's like an arm patch with a small needle can measure the interstitial glucose concentration in real time and provide data that the patient can use for their insulin dosing if they type 1, or can be sent to a central station or to a GP. There were other examples, including PROMs, where patients record, before they see a clinician, their physical symptoms, which joints are involved, what range of movement they've got, and all of that information can be sent in advance of a consultation. And then, just to make a final point, in a still unpublished piece of research that we're doing at Henley with an unnamed large insurance group, we are systematically looking at the, if you like, the old-fashioned time and motion study of a classic medical consultation to see which elements are really essential for the doctor to do personally, which elements could be done by someone else, and which, if you like, are redundant or less applicable in the times of COVID. And no surprise, we could engineer, reverse engineer, value engineer a lot of steps out of the consultation by doing them in advance online. For example, filling in online questionnaires, using chatbots to interrogate symptoms, using chatbots to automatically book repeat prescriptions. There's no necessary reason for someone to drive to a consultation, park, see a doctor, sit in a possibly COVID-infected waiting room. You can do that online. You can arrange a sick certificate online. There's plenty of admin that we can engineer out of the doctor's life. And guess what? The doctor's quality of life improves. The patient's service improves, so they get what they want quite quickly and efficiently. So the user experience is better, and you get better outcomes and better use of resources. But another very interesting thing happens, and we're hoping at some point to quantify this, so don't quote me, it's still early and a work in progress, but it could be that 30% of a standard consultation is not redundant, but could be engineered out from the doctor's perspective, and a nurse practitioner or a practice manager could do those things in addition as part of the support team. And what happens now is the doctor gets more time to spend with his patient, more time to think, more time to enter his clinical or her clinical notes, can write a better referral letter with more content. online order laboratory tests, imaging, or other follow-ups like a written prescription. And they also create extra capacity in the practice, which they can then choose to use in any way they wish. Now, here in South Africa, just to give you an example, apart from the improvement, therefore, in the quality of life of the doctor and the work-life balance and the improved service to the patient, they could use that. And we have a scheme going in South Africa where uninsured patients can be bought a healthcare voucher by their employer, or they can buy it retail, or someone can give it to them as a gift, and they can go and see one of 200 medical practices who are already contracted in for a tiny amount of money, like £15, don't quote me, and they can see a quality medical doctor for COVID or other defined consultations, and this will include the basic medication like paracetamol or whatever the treatment is for that condition. And then in addition, some of our medical practices are beginning to use this spare capacity created by telemedicine to see poor patients, uninsured patients, free. And that means that we're going to use our profession of doctors and nurses much better over the whole of the population instead of over only those who have, if you like, insurance or access.
Peter, thanks so much. That's triggered so many thoughts. And before I come to Naren, I'm perhaps going to ask John something, but also just pick up some of the key themes that you've raised there. And I thought you were going to joke about doctors then being able to spend more time on the golf course by improving the efficiencies. But actually, having the insights I do, both Sue and I have good friends in the medical profession. And we know the kind of actual degradation of the quality of their life, but it also impacts on their own sustainability and indeed their own resilience. And that leads to misdiagnoses, family breakup, stress, and their own illness. So I think anything that allows doctors to recharge properly will improve their efficiency in terms of how they operate. Before I come to you, Naren, and there's a few things we explored. John, what Peter also highlighted there was really, and I'm looking from the Henley lens here, you're really talking about business process re-engineering and design thinking. Is that something you teach these clinicians on the programs you're putting them through? Not everyone can do an MBA as a clinician, even though I think they possibly should. What are the key management learnings and business science learnings we could impose to make this more efficient?
It's a really good question, and I don't want to go abstract. I'll try and keep it practical, but I will do a little bit abstract for a second.
We'd be disappointed if you went abstract a little, John. We want some abstract thinking. Yeah.
So, this is the course that Peter's running. It's running at the moment. It runs for 6 weeks, 3 hours every Wednesday evening. And it's pulling together academics and doctors and practitioners and really experienced people from around the world. But it's also got a project tied into it where people are actually working on their own practices to make them virtualizing. So it really is helping people to do that. And that does require a number of skills. In that short period of time, you can't give a lot of insight, but we can do things like business modeling and the difference between business, vision, strategy, and a business model. They're three very distinct things. One's imaginative, one's big picture planning, one's much more like engineering the value of your organization. And you have to think about the sort of ways that people think. I mean, I know from my experience, you do too, and I'm sure Naren does, of course, is that you need an awful lot of focus when you're doing some particular work. And that focus requires a type of thinking. You need broad situational awareness, but you need laser-like focus on detail as well. So it's quite difficult to be doing that and then motivating people, engaging people, thinking of a business plan and all that. So the distraction from the focus is awfully difficult. And I think that's one of the reasons that doctors like the idea, but we haven't translated it into practice. There's about 3 skills that are important. One is critical thinking. That's the ability to see things from diverse perspectives. Now, typically, in a flight crew, you force the flight crew to do that. You have particular protocols. And increasingly, if you read that book, Black Box Thinking by Matthew Said, a Financial Times journal, really good book. Increasingly, you'll see, and you've alluded to it, checklists in hospitals, more group assessments, more stepping back and looking at things. And I'm sure, and I know nothing about this, of course, that the diagnostic process must be hugely increased by that, as well as all the sources of data that Naren was talking about. So that's critical thinking, where you detach yourself and take a third-person position and see the opposed ideas. The next way to come at it is systems thinking. But we look at objects, but it's the relationship between these objects that matter. Now, of course, in medicine, the metaphor is powerful, like whole system medicine. But there is this idea of the septic focus. You know, you drink too much beer. You know, you've got kidney problems. So you go to the kidney specialist and he says, well, drink whiskey instead. That'll solve the problem with too much fluid. So you go to the liver specialist next, and that's the septic focus. And you've got to avoid that sort of challenge. So you've got to see things systemically, multiple things. We look at the things, but very rarely the relationships between them. And then when you've got several things, how that whole system works, you can teach that, and that's important. But finally, there's a sort of thing more like computational thinking, where you're thinking and, but, yes, no, if so, that sort of thinking. There are all types of thinking. And you mentioned design thinking, where you dive into an uncharted territory, look at all the aspects of it, you suspend judgment, you get all the qualitative data, you mix it around, the patterns start emerging, you get the sense of a hypothesis or possibility emerging. You then try that, you prototype it in sort of rough, ready, rapid ways. You know, even with bits of paper and things, you get it going. And then when you build that up, you can start launching a prototype. You go into a sort of U of exploration. Now, all of those are things that people do naturally, and I'm sure that doctors do naturally. But to ask a doctor in a GP's practice or to virtualize their practice and do all that at once, we've got to translate that into checklists, into capabilities. Academics' position is to give you things that you can use, you can understand well enough that you don't need to have to, but you now use these techniques. And they're qualitative, and they're often you're vaguely right rather than precisely right. Better be vaguely right than precisely wrong. But, you know, so you get to the vague zone and then you laser in. And I think it's redolent with rich metaphors across the domains between business, aviation, and medicine as how to do these things. And I think that's how we must think about it. You know, we mustn't think of this as being difficult. It's actually very practical and normal. And you can approach building your practice in the same way as you can approach many other things. Thank you.
No, thanks, John. And Naren, that kind of makes us think back to last year when we were designing the Birmingham Breast Group customer experience. And I'm very aware that you're in surgery pretty much back to back all day, whilst trying to lead Birmingham at the UK's biggest breast clinic, fighting for surgery time, managing nurses, managing logistics, and actually just reflecting on actually how hard it is to step out of your own kind of wheelhouse where you're thinking of surgery to look at strategy, vision, customer experience. And I remember the debate we had around chatbots and how appropriate that would be in terms of engaging with our patients. But coming back to the question now, and perhaps some observations from your perspective, what are the diagnostic tools that are available and the specific disciplines? And then perhaps maybe comment on some of John and Peter's observations as well. I know we're entering lots of rich veins of topics here, but what are you hearing?
So before I sort of answer that, could I just give you a demonstration of how we've moved forward? So the background that you're seeing behind me is a digitally enhanced background of the NHS with our lovely 1960s decoration and the desk and the filing cabinet. And that's what we can do nowadays with digital technology. No, I'm joking. This is actually my office in the NHS. And apologies, it's not the same background as yourselves. So in terms of where we are with telemedicine, so I think there's loads of things that we are already doing. For example, we have suspended in Birmingham, we've suspended, you know, the results clinic that we had, for example. In the past, we used to see all our patients to give them their results. We can now do that virtually. So, but you have to self-select the patients because we have a diverse population, whether they're young, old, limited access to internet, language barriers, social barriers, intellectual barriers. So it's about self-selecting that, but it's definitely successful, it's doable. And one of the big lessons I've learned through this whole process is that actually patients, when they're given a diagnosis, whatever it is, they want treatment tomorrow. That's natural. If that was myself or a family member, I get that. But what I try to instill in individuals is that actually it's not the treatment that's really important. It's the stuff that comes before it. It's making sure, have we done this scan? Have we done that, you know, testing of this molecular profile? And it's when we try to circumvent that process, that's where we fail, I think. And I think telemedicine is really sitting at a very exciting opportunity to allow things like the Birmingham Breast Group, for example, to actually take that out of the equation and do that remotely, electronically, within a group which has got excellence, and they do that day in, day out. So I think that is definitely something doable. What really resonated with with what Peter mentioned was about actually giving something back. Because yes, we in the NHS will look after all individuals, but I guess there's the wider population. And for example, one of the sort of the ethos, I imagine, of our group in the Birmingham Breast Group is actually we'd like to be in a situation whereby those who don't have insurance, or those who can't access 17 international clinicians to get an opinion, can actually send some message at a fraction of cost, actually get a meaningful recommendation back. And that 9 times out of 10, I imagine, will reinforce what the local team are saying, but it speaks volumes to actually have that looked independently and corroborated by a group of individuals working in a collaborative way. So I think that's a very important tool and learning that we've come out of COVID. We're all sitting here today as a result of COVID. Otherwise, I'm sure I would have been on a flight to Joburg to join in with yourselves. But clearly, that's not happening. So I'm sitting where I am. But I think there's an enormous amount of potential that is yet to be realised. I also have to say, sorry, that John's comment about beer and whiskey and mixing them together resonated pretty well with myself as well. So I appreciated that comment.
Thanks, Naren. It's interesting. I think a couple of things I want to pick up on there. I think in South Africa, we've talked about the National Health Initiative for years. So we have the most unequal society in the world. If you look at the Gini coefficient here in South Africa, we have world-class clinicians, world-class schools, alongside some of the worst hospitals, some of the worst schools in the world, if anything. And I think that's something that we can't be proud of. And I believe the Birmingham Breast Group can address some of those inequalities by actually, yes, targeting the demographic that is on this call, that is on this webinar, our members, but also embracing that spirit of Ubuntu and helping out our neighbors and treating our community and ecosystem as a village. But I think there's this big assumption that we have unlimited resources in the UK. So maybe you could just highlight some of the challenges that the NHS is facing in terms of resources, the scale of treatments that you're having to provide, but also you spoke a bit about the challenge of diversity and inclusion. Not everybody is intellectually, socially equipped to actually benefit from some of the services you offer. So maybe you could just comment on that. Then I know Jeffrey Rothschild, Terence Naidu, thanks so much for the feedback. We've got quite a few questions that are coming in that Cecilia will feed in after you perhaps just comment on the scale of the NHS and some of its challenges, and maybe looking at your practice for one.
Yeah, so it's a massive privilege to actually be in the NHS serving our patients, but we have, over the last 12 months, just like everywhere else, have had some significant challenges. And we went through a phase when COVID phase 1 hit us, where we were diagnosed, the tap was on, if you can imagine, the tap was on, but there was nowhere for those individuals to go. So by that I mean we were diagnosing cancer and telling patients, I'm sorry, you've got this cancer, that cancer. But then for a period of 3 weeks, we had nothing to offer them. And that was absolutely heartbreaking and soul destroying, to be telling someone, you've got this problem, but I've got no operating slots, I've got no theatres to operate on. So in Birmingham, actually, we've had probably the worst experience with COVID, mainly because at University Hospital Birmingham, we actually have the largest intensive care unit in all of Europe in terms of beds. So we took on the largest amount of COVID patients in the country. And as a result, that sucked in most of the healthcare professionals into supporting that. And as a result, we are now in a really difficult situation whereby we are trying to restart services, and ultimately it's being quite difficult. And that causes a divisive healthcare professional. Me as an oncoplastic breast surgeon, I'm very keen to deliver the treatments for my patient group, but is a person waiting a hip operation because they can barely get out of their house any more important than my patient? Or is someone with a skin cancer or a bowel cancer? Or so now we are trying to ration things, and it's creating a very divisive, at times toxic atmosphere. And I think, you know, we will get through it, but we will be very bruised from it, and we're already finding that. So I think, in terms of equality and equitable access to healthcare, we're far from that, and we've taken a few steps back. But I think, you know, all of us are on this call because we're sort of massively invested in healthcare. I've got no doubts that we will be, you know, getting there in the near future.
Now, thanks, Aaron. And I think I'm always trying to I know Cecilia's going to come in with audience questions now, but I know this is perception in South Africa. The streets are often paved with gold in the UK, and the NHS is there with this endless supply of resources. But actually, the NHI will bring different challenges, which I position to Henley to say we should incorporate this into the training of clinicians and people in the medical practice, starting with organizational culture, and actually communication across disciplines, but then moving into kind of operational managerial challenges. Cecilia, I believe we've got some questions from the audience.
Yeah, just something that really speaks to what we've been exploring here, and it's around, obviously, for a multidisciplinary team coming together virtually from all over the world, we do have to rely a lot on notes and reports, as Naren said, but at some point you do need some sort of physical examination scans and the like. How can we, I think the questions are coming in around what sort of diagnostic tools are being developed or are already available that can be used virtually. And I think this is where TytoCare device comes in. Also, we've got Terence, who's also told us about what they've developed already. And I'll let Terence just very quickly tell us about that. He's posted something in the chat as well. But I think it'd be good to hear from everyone what you've actually seen in terms of those diagnostic tools. And the question particularly came from Zahir Hendricks from Westgrow, saying he's interested to hear everyone's thoughts around medical manufacturing for the future. What is that going to look like? He's specifically thinking around oxygen tanks and ventilators, but also just generally speaking, how is that being impacted by the pandemic and a new way of virtual consultations? But first, Terence, if you don't mind, I'm going to allow you to talk. And if you quickly want to tell us about what you've done with your X-ray development.
Thanks, Cecilia. It's more than just X-ray developments. It's across the radiology spectrum. So it's X-rays, ultrasound, and mammography models. And we use artificial intelligence to recognize patterns in these various modalities and images. And we can detect 20 different pathologies on X-ray images, one of them being COVID pneumonia. And we can literally analyze around 2,000 images per minute. So it's around 2,000 times faster than a human doctor. The difference between our models is that it was actually developed by radiologists for radiologists. So it's not something developed by data scientists where they use their models to validate themselves. Our models have been validated by radiologists specifically. We've implemented in the Northern Cape at Kimberley Academic Hospital, and at Pretoria Academic Hospital, we've implemented our COVID model. So we're assisting academic hospitals, and what we've realized is, we've got our head office in the UK, and we've realized that while we think our issues in South Africa are pretty specific to South Africa in terms of waiting times, where you have patients going to government hospitals, getting a chest X-ray done, and being told, "Can you come back in a month, and we'll give you your results." Exactly the same thing happens in the NHS. X-rays are not being read. There's a lack of resources. The NHS actually farms out a whole bunch of their images around the world to get analyzed and sent back to doctors to confirm with their patients. So we're not unique. It is a problem around the world. Doctors or radiologists don't like reporting on chest X-rays specifically, and they just pile up. So how would you know which are the most urgent cases when you come in as a doctor? Our model helps prioritize and tells you what the urgent cases are. So yeah, it's we're using AI to not replace jobs or doctors, but augment. And where there's a lack of resources, we can our platforms and our models are used to almost have the first reading, so you get an initial diagnosis before verification by a qualified radiologist.
Thanks, Terence.
Thank you. Thanks very much
Cool.
for that. I'd love to hear from the panelists what your thoughts are on the use of these diagnostic tools within your multidisciplinary teams, and particularly, Peter, if you can maybe tell us more about the TytoCare.
Okay, thank you very much. Yes, look, this is obviously the way of the future. What we're trying to do from a process point of view is engineer out repetitive tasks which human beings find dull and which are fraught with mistakes. And I speak as someone who spent, decades peering down microscope looking at thousands of cervical smears, as we used to do, for example. In Cape Town, we have a massive problem with tuberculosis, which is still diagnosed by sputum cytology. And at the National Health Laboratory Service in Greenpoint, there is a special lab that reviews more than 2,000 sputum samples a day. Now, if you ask human beings to do that, their error rate is going to be high. But that's the kind of task that a machine can do beautifully, and computers can be trained, as you've heard the radiology example, to screen these samples before the human beings look at them, and essentially then through artificial intelligence and algorithms, divide them into sheep and goats, if you like, and the sheep go through and are regarded as normal with a very high degree of accuracy, and the goats need to be looked at by a human being, and that massively reduces the workload. It's a very simple example. Now, on another level, one of our major insurers has brought out from America this Tyto, T-Y-T-O device, which is a kind of retail available medical remote monitoring device. That's a quick way. It's like a smartphone, but it's got ports on it and sensors which enable the doctor to look at I think the pulse oximetry, the respirations, the heart rate. You can do a sort of primitive ECG, and there are attachments for an otoscope, for ultrasound, and various other things. And this is now available. It can be delivered to your door during time of COVID, paid for by your health insurer. And what it's going to do is that people will take more responsibility who have access, and they can get a whole lot of real-time observations sent by telemetry through these sensors and the internet to their doctor's practice in advance of having a virtual consultation. Now, in the COVID example, we heard last night from Vicky Lee, using such devices, they set up a virtual COVID ward at the Royal Berkshire Hospital in Reading, where she works, and where she's affiliated. She's not a clinician, but she's an IT specialist. And in the virtual ward, the key triage point is the oxygen saturation. And it's very reassuring and it's humane to say to someone whose mother or granny is being admitted, look, you're not seriously ill. You may have COVID. You're still breathing very nicely. Your oxygen saturation is 97, 98. Why didn't you take this pulse oximeter, go home, and let your relatives keep measuring this? And if your sats drop to 96 or 95 or some trigger point, then you call the ambulance or you get brought in. That's a very wonderful way of providing home care. So this is the area that is opening up. The problems we face, and we can discuss later on, you have to see things in the round, is regulating these devices, getting permission, deciding on their errors, calibrating them, checking them, quality assurance. There's no standard software which will work around the world with interoperability to every practice or hospital or the state system. So while there are lots of problems, at least there are technical solutions which I think are going to empower patients and provide them with a device that allows them better home care, sort of a virtual consultation. And this is going to be the 21st century form of a home visit, where the doctor or the practitioner will basically, through the internet, parachute themselves into the home of the patient looking at the parameters and saying, look, you have some symptoms, but I'm not worried about you because your parameters on Tyto or a similar device, the Apple smartphone, I think, can do this. And there are other examples of Fitbit type devices that patients can use, which will keep those people out of hospital and make them less anxious and allow the hospital and the clinician to see the really sick people. And that is, again, how we create a bit of extra capacity.
Thanks, Peter. You want to jump in there, Naren, as well, your observations?
Yeah, thanks, Leon. I'd sort of challenge us all to take that one step even further. And I think the model in the future will be actually, we don't need to go to hospital. There's a lot of, unless there's clearly inpatient work that needs doing, a lot of the work can be delivered off-site. And that's one of the things that we're looking at. You don't need to go to hospital to have, I don't know, this or that doing. There's only a very limited number of things that one needs to go to hospital for. With using of whether it's artificial intelligence, home monitoring devices, we can actually set up and are actually in the process of setting up off-site locations, whether they're virtual or whether they're real, to reduce the footfall in the hospital and give patients better access, whether they're remote or not. And that model's already there, and it's something that we've already embraced over the last 12 months, and that's really been the catalyst for the future. And I think things like artificial intelligence, augmented reality, those are the extra tools that will help us to facilitate that. Now, clearly, we're going to have to, before we get there, take one little step back and figure out actually this disease process is sitting perfectly for that, or actually this disease process could benefit from that in addition to a human individual. So I think that work is already being done. I know in Birmingham we're already doing that. For example, I think Terence mentioned the artificial intelligence aspect of it. We are, the best known publication, I guess, is about artificial intelligence looking at the back of an individual's eye and determining whether they are male or female. We can't do that as clinicians, or we find that very difficult to. So there's definitely a lot that we're going to learn with artificial intelligence, and it just makes the whole situation a very exciting a time to be part of it all.
Yeah, and I agree, Naren, and I think the content is so rich we could deviate and go down various rabbit holes, which are all interesting. I'm going to drive it forward and actually ask the audience now. On this theme, we're moving towards this virtual utilization of artificial intelligence, virtual visits to hospitals, home treatment. What concerns do you have about virtual meetings and consultations? Is it around data privacy, how the data is used or stored, the security of the platform? We've all got POPI, GDPR regulations we have to follow. What is the impact of that? Potential for misinterpretation of information, intention or the tone, possible operational issues, or is it the diminished interpersonal connection? Be interesting to get the panel, the audience's view on those areas. Ema, you can throw them up as they come back, but I'm going to fast forward this conversation now. I'm really looking at internationalization, something that's, I know, Peter, you've got a great deal of experience of. Naren, we've got increasing experience of that, and we've got an aspiration for it. Singapore and Dubai have set themselves up as tourist destinations. How does this kind of now virtual agenda challenge that? And what are the opportunities for us to give world-class patient care from anywhere in the world in a borderless context? Perhaps, Peter, with your experience in the Middle East, I'll come to you first.
Okay, well, thank you. There are opportunities here, and I think what is happening is that the borders between countries and technologies are disappearing. COVID has encouraged that. And to give some practical examples of things that are actually working, and then we can speculate. In South Africa, there is a firm of radiologists here in Cape Town that has for many years had a contract to diagnose over 100 MRIs or CT scans a night. And I've been to that practice and had a look. So here we have a backlog situation created in the NHS for various reasons. and at a price which is much lower than a UK radiologist would charge, because they're being paid in rands, which is roughly 20 to the pound. This practice has 2 full-time radiologists who do nothing other than sit on the night shift and diagnose these MRIs. So in the morning, when the clinicians come to work at 9 a.m. in the UK, they have the report electronically in their inbox. And so that's an example. Another example is that in Mumbai, which is the home of about a third of the world's software, as you know, American-trained Indian radiologists, likewise, who are certified in certain states in America, are able to provide a real-time and store and forward kind of reporting system for cases in America. So these are examples. Now, Dubai has been trying, I ran hospitals and clinics and laboratories in Dubai for some time, is trying to set itself up as a tourist hub. I think it gets about 500,000 patients. And the idea is that patients are, in the best example, which is run by the Bumrungrad Hospital in Thailand, they have a massive hospital in Bangkok, but they have centers all around the world where patients are pre-screened before they travel, if they need to travel for surgery. So a lot of the preliminary workups are done virtually, which are in the form of questionnaires, virtual consultations, lab tests, radiology, all of that is done in advance. And then on a strict triage basis, clinicians in multidisciplinary teams in the more advanced country, let's say in this case Dubai, draining the subcontinent, shall we say, are able to assess if these patients are suitable, if it's worth them investing the money in the travel, and then the receiving hospitals set up package deals which include the travel. Now, in a reverse example, South African plastic surgeons have set up an example, I mean, this is great, called Tuck and Tan. You can fly from the UK to beautiful Cape Town, almost first class, stay in a 5-star hotel, have your plastic surgery operation, go to the beach, eat well, drink well, for less than it would cost to have the same operation done in the United Kingdom, because the overhead costs are so much lower in South Africa. So these are just some examples of the mobility that is happening because of telemedicine. The economic opportunities are there, and how we can now arbitrage between costs and revenues in different locations and provide better service at lower cost, thereby increasing quality.
And Peter, I mean, I love that example. I know here at the West Cliff, there were often people that would come and have a safari and a boob job, and then go back home, and it would have been significantly cheaper than doing it in the UK. But before I come to Naren, is there anything around the legislative framework that has made telemedicine, virtual medicine easier? I know we discussed something about the post-COVID context in South Africa that has changed before we went live.
Look, I think here there is a problem perhaps around the world, and that is, generally speaking, regulators tend to work behind the curve. They're a kind of lag indicator, not a lead indicator. They're not in the business of anticipating change. So, being respectful and courteous towards our regulators here in South Africa, the Health Professional Council, in its wisdom, I mean, what I was proposing in my MBA thesis 20 years ago was actually illegal. It was disruptive. It was not allowed in South Africa. The only kind of telemedicine which our Health Professional Council would allow was what we might call B2B, where a doctor in a base hospital, let's say in the Transkei, could access a specialist in cruelty care for a second opinion, sort of doctor to doctor. Now, of course, interestingly, and to its credit, in March last year, I can tell you the date, the 26th of March, so literally a year ago, our Health Professional Council showed that it wasn't Luddite, it was nimble and agile. And in response to COVID, immediately rescinded all those rules and brought in new rules, making it possible to do telemedicine, recognizing that this was going to keep social distancing between doctor and patient, and between patients, reduce the strain on outpatients in hospitals and so on and so forth. And since then, they've issued a number of modifications which are enabling, if you like. Now, what we're hoping is that when COVID is brought under control, if that happens in the near future, we will not go back to the state, state ante beforehand, but we'll keep the gains that have been made. And on the other side, which is linked to this, you have to also give some credit to the health insurers in this country. A year ago, a telemedicine consultation was not billable because it wasn't allowed, yeah? So the health insurers didn't have a code for reimbursement of a virtual consultation. WhatsApp hadn't come in as a form of consultation. Telephone consultation wasn't billable. Emails were not billable. And they applied their minds and they've recoded all of these procedures now with special codes. Now it has to be said, they have a vested interest. So whereas before they may have been against it for some reason, they're now very much in favor of it. One of the reasons is they only pay about 2/3 of the standard fee, which means there's a significant cost saving to the insurer. The doctors are unhappy about that because they feel they're losing revenue. So just an example of having to think in a business-like way about all the stakeholders' opinions. And they've had to negotiate in various fora, and we've got one of their negotiators on the course, Dr. Unban Pillay, who's been very good in bringing the sides together. But there's a third aspect to the regulatory side, and that is the medico-legal insurance. A year ago, if a doctor consulted a patient but did not see the patient physically, yeah, did not lay hands on the patient, and the diagnostic error was committed, then they were liable because in a very trite way, you didn't see the patient, did you? Literally. And now that's had to be reviewed. And we're now looking to policymakers, organizations like NICE, I hope, to lead the way with new clinical pathways and regulations and best practice guidelines in which they clearly state these cases are suitable for telepractice, for virtual consultation, and these are definitely not suitable. So, for example, no doctor would be consulting online for a heart attack or a ruptured ectopic pregnancy or a stroke. Those sorts of things will have to be filtered out. And what we'd really like to see, John and I and others, we'd like to see these pathways taught in undergraduate medical and nursing and allied professional courses, so that telemedicine is hybridized into conventional medicine, and that the new graduates actually know and work with, they're much more tech savvy than our generation ever was, and that this becomes the new normal in the future.
Thanks, Peter. I mean, so many shifting tectonic plates there in terms of addressing this new world of healthcare. Naren, what are you seeing? And I'm particularly interested in the opportunities for the Birmingham Breast Group to operate across borders. You talk about your heart being in Africa. We're here in Southern Africa. What are the opportunities there? But equally, what are the opportunities in the post-COVID context addressing some of the NHS backlog as well? It's be good to get your thoughts around those two key areas and anything else you've heard.
Yeah, so in terms of just sort of reiterating about what Peter said about the governance issues, I think that's a really important part of it. And I think, for example, what the Birmingham Breast Group's opportunity is about being an advisory group. Clearly, we're not asking patients to physically come for a physical assessment. It would be an advisory group whereby we've assessed the data in front of us, and clearly there'll be a quality assurance question. Is the biopsy that was taken in a remote destination, is that a reasonable biopsy? And clearly we're not going to be able to quality assure that, but the discussion around it will be a quality assured discussion. So in terms of what the platform may look like, for example, is a lady or a patient is diagnosed with a problem, whether it's in a remote destination in Southern Africa, or whether it's in one of the large cities, and they then send their information to us electronically in a secured package. And we then have our multidisciplinary meeting. We review the images in real time. We review the pathology in real time. We come up with a set of recommendations. Now, they are just recommendations based on our interpretation of the data, but there will be, it will be an advisory group that we look, and we would then come up with a set of recommendations that we would send back to the individual, maybe even a healthcare profession or even the patient, and then they can discuss with their local clinician as to whether this is reasonable, it's whether it's something that they can access locally, or if they have the means, whether they need to travel elsewhere, not necessarily Birmingham, neighboring large university hospital or neighboring country, whatever, but at least they then have that expertise behind them. So that's the way I'd look at it working. And there's no reason why, Southern Africa is a very large area and a diverse area. I've been privileged to treat patients from Ghana, Nigeria, and more recently Egypt. I've literally had 2 referrals from Egypt in the last 24 hours. So this model can work and does work, and there's also already precedence there. It's just about making sure we grow it, or in a way that we can then reproduce it across the other specialties.
Thanks, Noah. I'm delighted to say we're only halfway through our kind of pre-arranged discussion topics. So I'm going to move forward to one final subject area. And I think we're going to need to follow up. There's such a rich appetite to discuss some of these issues. So I look forward to getting a follow-up session in the diary. But John, really coming to you, and this would be our final topic. So I'd encourage the audience to ask any final questions in the Q&A. Most experts agree that communication is 70 to 93% non-verbal. And I'm intrigued as the appearing on video conferences and much of our non-verbal cues are missing. So we're wired to interact in a 3D manner, not in a 2D manner. How is this manifesting itself in how we communicate? What is being lost in some of these virtual sessions? I've met Peter today. I feel like I know him, but how can I replicate the 30 odd years I've known Naren and the 10 years I've known you? What is it we can learn from a business school context, from a leadership context, in terms of navigating our new 2D world?
Well, we can talk in a very sort of mundane and severe, quiet voice, or we can express and be there and be emotive and present. And you watch TV all night, okay? Every night you're watching TV, right? And that TV brings emotions out in you. And there's the industries of Hollywood and film industries and film studios and communicators, all who know how to bring emotion and presence and feeling into that screen. That's why we live on our screens now. It's interesting, there is more engagement sometimes in the 2D screen, and sometimes it's hypnotic and malicious, it's bad for our families, but it's more captivating. And so if we start to use the skills of that, and we are really trained not to do that, we're trained that professionalism is everything, and that is really important. I mean, if you get into Naren's environment or any hyper-professional environment, you're communicating super fast with really precise jargon and precise language that is exactly attuned for that. It carries so much meaning that only those people can fully understand. Used outside that context, it becomes obscurantis, bluffing, fog, or even trying to deceive people. So you've got to understand the languages you use, how you engage with people. And so it's absolutely possible to have a combination. Of course, there is some, I can't touch you. We can't touch each other, but we're not going to be touching much when we're having lunch anyway, are we? Frankly, I don't remember having lunch with you and holding your hand all day. So the point is, what I'm trying to say is there are many techniques that are within the communicative devices, within the technologies, within the emerging technologies, with the use of language, use of facial expression, etc., that allow us to really make that contact far, far greater than we might believe. To the extent I think it can have, I mean, I'm seeing you see people on screen with more detail quite often in the faces than you will at a distance. So it's a bit like, it's actually quite intimate. And that's why it's so tiring. I turn off my face when I'm on Zoom because research shows that it exhausts you if you see your own face all day. But I see that Peter has a point, but great question.
Thanks, John.
Thanks. I'd just like to add to that. Thank you, Jonathan. That's a brilliant answer. We must admit, and this is partly said with feeling and partly with science, as we do research on disaggregating the elements of the standard medical consultation for the new telemedicine use, that we lose a lot of diagnostic information in the no-touch environment. We have to understand that. I mean, I was, classically trained at TytoCare Hospital as a medical student, and we used to say, if you don't put your finger in it, you put your foot in it. And so no doctor anywhere in the world would want to diagnose a patient without a physical examination in an ideal world. And I think what we're going to have to learn, and this is where medical school educators and policymakers and postgraduate trainers and NICE and all the organizations which have inputs into the training of doctors and nurses will have to work out what kinds of omissions are acceptable for which conditions. A surgeon is going to have, and Naren could comment better than me, but I think a surgeon would be very uncomfortable operating on a patient that he hasn't physically touched, because there's a huge amount of diagnostic information. As you know, medicine really was about using all of your 5 senses to get information in the days before we had fancy imaging and tests. And we mustn't kid ourselves that virtual is better. Virtual is inferior to full touch-based care. And there's another interesting aspect we mustn't forget. I think the laying on of hands, literally, is an important psychological anxiety relieving step for a doctor and a patient. I think if you've got children, or if you yourself have been ill, the moment that blood pressure cuff goes on, or the doctor's looking at you or looking at your child, you feel reassured. So it's an emotional two-way street. There may even be a placebo effect in touch, but we are not going to write it out of the system. We're just going to try and engineer it out where it isn't essential, but there will be other cases where it is essential, and it should never end.
Thanks, Peter.
Can I chip in again? Yeah, just very quickly.
Yes.
Because if you read people like Yuval Noah Harari, who's a historian and a futurist, and he starts rationally projecting the future of technology growth, where devices come beneath the skin barrier, nanotechnology. In the near future, this isn't even far, with the sort of implants, with all the stuff that will inevitably be happening, and with deep connections through. You can even imagine some form of surrogate touch. It won't be the same, with devices you can see with a doctor. You can manipulate devices. I've had them. An operation with the surgeon on the other side of the room working on you, not seeing you. It could be 100 miles, 1,000 miles away. But the technology progression is going to take this field far, far further, quicker than any of us can imagine. And I think that is where part of our brains need to be. Reading and understanding how rapidly the interface between rational and effective emotional thoughts come together, and how technology can not just simulate, but start to engage in ways that are felt real for people. Deep simulation, the games that kids playing, and beyond that. So when you see AR and VR and AI all starting to come into play now, the near future takes us into a whole new domain. And I can't speak for Peter as a doctor, but I can say that it's inevitable that the change in this sphere will be huge, as it will in business generally.
Thanks, John. Thanks. Perhaps we can look at the results of that final poll, and then Cecilia, you can feed in any kind of final questions before we invite the panel for their concluding comments. What concerns do we have about virtual meetings? 25% around data privacy, 42% around misinterpretation, so the authenticity and veracity of those outputs, and then a small amount as possible operational issues, diminished interpersonal connection. So Cecilia, are there any final questions before we perhaps ask the panelists to comment on that and then indeed share their concluding final remarks this morning?
I think, I'm not sure this is everyone's specialty, but it is a really relevant question, a little bit different. We've covered most of the other questions, but Rory van der Merwe is asking something that we've not quite touched on about mental health. He said, how can mental health and the invisible wounded, emotional and psychological needs, how can that be included alongside physical medical care and in the virtual space? I know you can have a virtual consultation or counseling session with someone, but again, there's something that, as you've touched on, the physical touch, that bond of trust that might not quite be the same. How can we change the model to take care of that as well?
Perhaps I can invite you to answer that individually and combine it with your concluding comments. And I know, Naren, you're a head boy at our school, so you're always bright enough. You can go first.
Well, thank you. I'm also sort of privileged to be married to a psychiatrist, and
Yes.
I'm also sort of aware that over the last 12 months, there's been the obvious individuals who've been diagnosed with COVID and had their outcomes, but there's that invisible population that is not insignificant, that has had the trauma of lockdown or whatever it is that we've all been living through. And how does one address that? Great question. I don't know is the answer. I think there are definitely tools out there, because I sort of live with my wife who uses those tools, whether it's access to psychotherapy, cognitive behavioral therapy, which can be done virtually, which can be done without having individuals there face to face. In terms of the more psychiatric end of the spectrum with mental health issues, I do think that group of individuals have had a really poor service. It's the thing that when we get home, we argue about a lot: cancer, breast cancer, Angelina Jolie, all of this sort of stuff, high profile stuff. Mental health, not so. And it's really the sort of thing that we overlook, but it's so prevalent. In the UK, 1 in 4 GP consultations is about mental health, and it's pretty true to say that mental health is mental wealth, and it's something that I imagine resonates well with everyone here. How can we look forward? Well, we've got all the individuals here today. We've got the British Chambers, we've got the Henley School of Education, we've got ourselves. We're all here to promote better understanding on how we can collectively, collaboratively look at that in whichever shape or form that is. So I'll just, as my sort of parting message, say use us. Use, for example, the Birmingham Breast Group. Use it as a conduit to test the waters to see, actually, can we make virtual consultations in this specialty work? If it can work, let's use it to look at the mental health group. Let's use it to look at the next specialty. So I guess that would be my sort of summation of where we are.
Thank you, Naren. And I'm glad you pulled on Ria's experiences there, because I remember debates Ria and I have had around how members of the Afro Caribbean community are disproportionately affected for mental health issues in the UK. Here, being in Africa, in a very patriarchal, macho society where we don't discuss mental health as men, something John and I have discussed, and I've seen in the corporate space, around men being all invincible, all powerful, and having physical breakdowns, mental breakdowns, suicide, heart attacks. Mental health is really linked. So in our supportive ecosystem, come to the chamber, we can discuss these issues. And I know, John, it's a subject close to your heart. And in my concluding comments, I'll come back to you now in the BBG, but no, really, really good insights there that we don't tackle aggressively enough within an African context. Perhaps on that, John, an opportunity to come to you for your, sorry, Peter, I see you putting your hand up. Yeah.
Very quickly, just to add to what Naren and John have said, I think I had dinner with a psychiatrist socially a couple of days ago, and I also know some clinical psychologists. They all say that telemedicine has really helped their practices. People who were nervous about coming in because, somebody might discover that they've gone to a psychiatrist, or all those sorts of issues go away in the privacy of the home, where the psychiatrist or the psychologist comes in. And because it's a no-touch profession, it's in many ways lends itself to telemedicine. I saw in the New England Journal of Medicine a week ago that there's a professorship of telepsychiatry going at one of the New England medical schools, which is quite amazing. And I predict that eventually all medical schools will have professors of digital healthcare like Vicky Lee, and they will tend to have professors of other tele fields that are, if you like, the leaders, and that the future will change. In 5 years' time, if we do this again, Naren will not have a filing cabinet in his background because everything will be digital, and so on. So the world is going to change radically.
Yeah, I know. Thanks, Peter. That's interesting. John, I know it's a topic close to your heart, and perhaps to summarize as well your final remarks.
It really is. It's so many wonderful points that Naren, Peter, and the listeners brought through, and you yourself. It's such an important issue. It cannot be unsaid. I sometimes feel we're a bit like the amphibian, or a bit like the creature coming out to sea into the air for the first time. The fish doesn't notice the water it's swimming in, but we don't notice the air, we breathe it. And I think connectivity, virtualizing, working, that's like the air we're going to be breathing. We won't notice it. It's just what we do within it. And it's absolutely certain, certainly for the people in our environment, students, executives, staff, other people, that the challenges in normal life are hard enough, and the dynamics you've talked around women and issues of race and issues of difference generally, and in many, many ways are huge. And they're really hard to handle. And with COVID now, what's happening is when people are suffering, families are suffering, they're locked into an environment of their own and trying to deal with this. And what we've realized that leaders need to develop empathy, much more empathy. Now, that doesn't mean, the thing about empathy, we think it's holding a hand and just having a shoulder to cry on. It's not really. There's big E empathy and little e empathy. If somebody's in front of you and they have a huge problem and they want to do something that's special for them, but it affects others, they want to take leave or whatever it is for a year, and there's everybody else. You want to help that person, but as a leader, you've got to have the big E empathy. You've got to understand the system, the multiple people you're dealing with. And it's calling on us as leaders and all of us to think differently, to take on more strain, to engage with people. And who's trained us to do that? And who's trained us to listen to people and empathize with people going through so much? So leadership in this virtual world, it's a bit like the paradox of the European Union originally. By bringing multiple different states together into one union, they all develop their own quirky individual identities, even more so than normal. And the virtual world, while it brings us all together, it makes us feel our own stuff more. So we've really got to engage with it. And I agree with you, as men, we need to talk about issues of what masculinity means and what it means to be a father, what world we're bringing our sons into. And again, our daughters, our partners, what does it mean now to be a leader in this world? So the virtual world, paradoxically, I think, raises these issues of personal development to an ultimate high. And Yuval Noah Harari himself said this. He meditates hours every day. He takes a month off every year. And he specializes in focusing on his mental well-being, as Naren said, it's his mental wealth. And I think the capacity to know yourself, to understand your shadows, to understand how to differentiate between, discern between fake news and real news, to understand why you would leap onto things and what your psychology is, becomes the super master power of all leaders, far more than it ever was before. And that requires us to sense who we are, be vulnerable, and go through some quite radical changes. And the paradox of the virtual world to me is it's going to amplify and accentuate our own personal needs to develop self-insight and mastery.
Thank you, John. I couldn't agree more. Thank you very much. And Peter, perhaps finally coming to you, kind of any concluding comments, remarks you have after this kind of rich engagement this morning?
Well, I just commend you for putting this together, and thank you for the opportunity. There are, I suppose, eternal optimists among us who, whenever there's challenge, see opportunity, and we see, if you like, a possible upside. Our mission in starting this course, Future-Proof Your Healthcare Practice, was exactly as Jonathan said. We realized, Jonathan's married to a GP, and I mentor a large number of young UCT medical students and some Rhodes Scholars in Oxford who are medical. And we can see that the profession is in trouble. And, I take my hat off to Naren and other clinicians who work through this. Nobody really saw COVID coming. It had a massive impact on the healthcare systems, which in some cases were found wanting. But what we wanted to do was to give the profession a hand up and, to find solutions to problems and to say, look, there is another way. We can co-develop it. We don't have all the answers. But we believe in the power of collective intelligence. And by bringing everybody together, not only do we encourage people, doctors and others, to realize that there are better ways or other ways, additional ways of doing things. We call that the hybrid model, where you pivot from keeping as much of your face-to-face practice as is appropriate for you, a surgeon, let's say, or a gynecologist, more so than other practitioners, and you let go some things that you can afford to let go. And then you embrace the technology and you go with it and you help to create the future and be part of the future. So that's how we see it. It's been a wonderful opportunity, and our course has gone well, and we're getting very positive comments, and we're looking forward now also to be more inclusive. We're extending it specifically to the nursing profession and the allied health professionals. We have a very active group of physiotherapists on our course at the moment. And we also want to close some of the divides, the digital divide, the rich-poor divide, and the divide for those who don't have insurance. And we think that by creating spare capacity in the private practices in South Africa, which are numerous and well-resourced, many of them will be able to give a hand up to those who have nothing. And that's the way to get, you know, to do more with less, to realize we've got to play the card that the country's been dealt. We have X number of doctors, Y number of OPDs and surgeries, and Z number of nurses, and the whole country needs them, not just the 20% who are privileged. So that's where we see the future. And also we think that some of the answers to what the government here is looking for in terms of national health insurance and a way forward can be provided from forums such as this and from medical and business schools, and that the problems are soluble. I have a little private view that for me, a problem is a kilometer wide asteroid heading for Cape Town. Anything less we can deal with on that note.
Thanks so much, Peter. Really appreciate it. And Cecilia, any final comments from yourself?
I just think perhaps a little more generally speaking, but touching on what John said, we've got greater connectivity, greater ability to connect with more people in different places, which is great. You're no longer necessarily limited by a car breaking down or not having the money for petrol, as some people would have. You can do things differently, and that's a good thing. I do think, as John also said, there is the risk that we can become, even though we think we're more connected than ever, we actually become more introspective and self-absorbed in a way, because we're sitting looking at ourselves in a screen in our own living room the whole day. So I think it is about moving to a hybrid model, as Peter said as well. And I think being deliberate about your interactions, and also deliberate about being present, whether you're sitting physically across from someone or on screen. You might have to be present in different ways, and you will have different cues that will be working for you or not. And I think that would be one of my key takeouts of today.
Yeah, thank you, Cecilia. And thank you to the panelists, John, Naren, Peter, really kind of rich contributions that have triggered so many different subjects that I think we can explore in future fora. Thank you to Ema and Mission Control, and to Leslie for putting us on the right place in the right time, and to Venice for supporting behind the scenes. Thank you to you, our members. And I'm just kind of inspired to revisit a conversation that the British Chamber Board and I had last week, which John was part of, and really reevaluating our purpose as an entity and an organization, which Naren's reminded me of, Peter's reminded me of, and John's reminded me of. You know, we are here to contribute to a greater society. We are here to enable a better business environment by taking up some of these challenges like NHI and providing the ecosystem to create these solutions. We're here to help you grow, be Henley, be the Birmingham Breast Group, be you as an individual. We want to help you grow by putting events together like this, but giving you access to cutting edge intelligence and information, which I hope we've done today. Just reiterating some of the points, combining academia with business, with healthcare, we really can solve so many challenges that we face here in South Africa, but globally, by reaching out to our international ecosystem. And the greatest predictor of success in any individual and any leader is actually self-awareness and emotional intelligence. And that's research that's kind of been gained out of MIT that I know Henley use on those programs. So I really do encourage us to look at our own self-development, our own self-awareness, look at the programs at Henley. We're all in and around the healthcare space. Should you want to get connected with Henley, please reach out to us and we'll make sure you speak to the right people. Likewise, watch this space for the Birmingham Breast Group and ways to access us through that. Looking forward, the importance of healing hands and touching. We're going to actually be in Cape Town first week of May for our first in-person event since lockdown happened, with more to follow in Joburg very soon. So please stay connected. I thank you all again for joining us this morning. Wish you a restful Easter and look forward to connecting in the coming weeks. Thank you, everybody. Have a great day.